Let's talk about the streptococci. The streptococci are gram-positive spherical bacteria which form pairs or chains during growth. They are widely distributed in nature. They are a large heterogeneous group of bacteria, but there is no one system to classify them. There are four major categories, however, to describe our streptococci using colony morphology and hemolytic reactions, serologic specificity of the cell wall group specific substance, and other cell wall capsular antigens, using biochemical reactions and resistance to physical and chemical agents, and as well as ecologic features. The characteristics of the medically important streptococci. Streptococcus pyogenes are group A strep, which are beta hemolytic streptococci inhabiting the throat and skin. Streptococcus agalactiae are our group B strep, which are beta hemolytic and lodge in the female genital tract. We also have Streptococcus dysgalactiae, Enterococcus fecalis, and other enterococci. Streptococcus bovis, Streptococcus aeruginosus group, the viridin streptococci, which are usually not typed or untypable and exhibit either alpha hemolysis or no hemolysis at all. Our Streptococcus pneumoniae group, which is also non-typable and exhibit alpha hemolysis and lodge mostly in the throat. And lastly, our Streptococcus species. For patterns of hemolysis, note that there are many species that are able to hemolyze erythrocytes in vitro, exhibiting beta hemolysis, alpha hemolysis, and gamma hemolysis. Take note also of the so-called Lancefield classification, which forms the basis of serologic specificity of group-specific carbohydrate determined by its amino sugar. Take note the amino sugar for group A strep, group B strep, group C strep, group D strep, and group F streptococci. Capsular polysaccharides also help in the categorization of our streptococci. Note that Streptococcus pneumoniae is categorized into more than 90 types owing to the antigenic specificity of its capsular polysaccharides. Examples of biochemical reactions include sugar fermentation reactions, tests for presence of enzymes, and tests for susceptibility to or resistance to certain chemical agents. About the streptococci of particular medical interest now, beginning with Streptococcus pyogenes. Streptococcus pyogenes contains the group A antigen. It is a prototypical human pathogen associated with local and/or systemic invasion, as well as post-streptococcal immunologic disorders. They form large, 1 centimeter zones of beta hemolysis around colonies greater than 0.5 millimeter in diameter. For biochemical reactions, they are positive for the PYR test and are also susceptible to bacitracin. The typical organisms are spherical or ovoid cocci arranged in chains. They have striking diplococcal appearance. Occasionally, rod-like forms are seen. They are gram-positive, although may lose the gram-positivity and become gram-negative with age and death of bacteria. Most group A strains produce capsules composed of hyaluronic acid, which helps impede phagocytosis. And they have hair-like villi which project through the capsule. This villi consists of M protein covered with LTA or lipoteichoic acid. Other cell wall components include protein, carbohydrates, and peptidoglycans. Characteristics, they form discoid colonies of about 1 to 2 millimeter in diameter, and they exhibit beta hemolysis. For growth characteristics, growth tends to be poor on solid media or in broth unless enriched with blood or tissue fluids. Growth and hemolysis are aided by incubation in 10% carbon dioxide. Most of our pathogenic streptococci grow best at 37 degrees, which is body temperature. Therefore, they love living in human beings, as that is our normal body temperature. The facultative anaerobes also grow under aerobic and anaerobic conditions, and the peptostreptococci are categorized as obligate anaerobes. Note that our Streptococcus pyogenes also vary in terms of colony forms. So we have the matte colonies and the glossy colonies. For the matte colonies, these are organisms that produce much more M protein and are therefore generally virulent. The glossy colonies, however, contain less M protein and therefore exhibit less virulence. Let's go over to our antigenic structures, which include M protein, of which there are about 150 types. Therefore, repeated infections with group A Streptococcus pyogenes can happen, and this plays a very important role in the pathogenesis of rheumatic fever. Other antigenic structures include T substance and nucleoproteins. Let's go over now to the different toxins and enzymes associated with our Streptococcus pyogenes. First of which is streptokinase, otherwise known as fibrinolysin. This is produced by many strains of our group A beta hemolytic streptococci. It functions to transform the plasminogen into plasmin and is given intravenously for the treatment of pulmonary emboli, coronary artery, and venous thrombosis. We have streptodornase, otherwise called as streptococcal deoxyribonuclease, which depolymerizes DNA. We also have hyaluronidase, which is also called as spreading factor because it aids in the spreading of infecting microorganisms. We also have the pyrogenic exotoxins or our erythrogenic toxins, of which there are three antigenically distinct forms, A, B, and C, of which exotoxin A is the most widely studied. We also have diphosphoridine nucleotidase, and more importantly, the hemolysins, streptolysin O and streptolysin S. Now let's talk about the diseases attributable to invasion by Strep pyogenes or beta hemolytic group A streptococci. You have erysipelas, the portal of entry of which is the skin, leading to massive brawny edema, a raised lesion, with rapidly advancing margin of infection. The second is cellulitis, which is an acute, rapidly spreading infection of the skin and subcutaneous tissue following infection associated with mild trauma, burns, wounds, or surgical incisions. Cellulitis is described as painful, tender, and erythematous. The lesion is not raised and it has indistinct margins of infection. Erysipelas, cellulitis, and necrotizing fasciitis, or otherwise called as streptococcal gangrene, which is an infection of the subcutaneous tissues and fascia. It is extensive and rapidly spreading necrosis, and also typically attributed to flesh-eating bacteria. Other diseases include puerperal fever following vaginal delivery and bacteremia or sepsis, which can be rapidly fatal. Now let's talk about diseases caused by local infection with Streptococcus pyogenes. First of which is our streptococcal sore throat or streptococcal pharyngitis, which is the most common infection caused by beta hemolytic Streptococcus pyogenes. Streptococcal pyoderma, otherwise called as impetigo, which is defined as a local infection of the superficial layers of the skin, especially in children. The lesions consist of superficial vesicles and eroded areas whose denuded surface is covered with pus and is later encrusted. Impetigo is associated with Streptococcus pyogenes M types 49, 57, and 59 to 61. And patients with streptococcal pyoderma are more likely to have glomerulonephritis in the future. This is how impetigo looks like. Notice the lesions, they look as if they are pizza crust lesions and are therefore called as such. Now let's talk about invasive group A streptococcal infections, toxic shock syndrome, and scarlet fever, all of which are associated with shock, bacteremia, respiratory failure, and multiple organ failure, causing death in 30% of cases. These are associated with Streptococcus pyogenes M types 1 and 3, which make exotoxins A or B, and therefore these are associated with severe infections. Pyrogenic exotoxins A to C causes scarlet fever, which appears as a rash on the trunk, appearing after 24 hours of illness and spreads to involve the extremities. For your staphylococcal toxic shock syndrome, it is no less different from our streptococcal version. For the post-streptococcal diseases attributed to Streptococcus pyogenes, these are described as diseases that follow a latent period of about 1 to 4 weeks following infection with Strep pyogenes. These diseases are not due to the direct effects of bacteria, but due to a hypersensitivity response. Note that glomerulonephritis usually follows skin infection, or impetigo as we have earlier seen, and rheumatic fever usually follows infection of the respiratory tract or our strep throat or strep pharyngitis. Acute glomerulonephritis develops 3 weeks after pyoderma or impetigo. It is associated with nephrogenic strains with M types 12, 4, 2, and 49. This is initiated by antigen antibody complexes on the glomerular basement membrane of the kidney, and the patient will exhibit hematuria, proteinuria, edema, hypertension, and urea nitrogen retention. Few patients die or develop chronic glomerulonephritis, and the majority will recover completely. Rheumatic fever, on the other hand, is the most serious sequela of Streptococcus pyogenes, leading to damage to heart muscle and the heart valves. This also follows a 1 to 4 week period after strep throat, and the patient exhibits fever, body malaise, migratory polyarthritis, and carditis. There is thickening and deformation of the cardiac valves, and rheumatic fever can be reactivated by recurrent streptococcal infections. Remember, there are several types of M protein, up to 150 types, and therefore, streptococcal infection can be or can recur that many times. For diagnostic laboratory tests, the specimen depends on the nature of infection. Culture of throat swab, pus, or blood can be done, and antibody determination using serum can also be done. For smears of throat swabs are not as helpful because of cross-contamination with viridans streptococci. Culture is done using blood agar plates. If anaerobes are suspected to contaminate, then therefore use also anaerobic media. And we can also do antigen detection tests. And serologic tests, particularly the ASO titer, which is still most widely used right now. Remember that resistance to strep throat and other streptococcal pyogenes infections is M-type specific. So recovery from infection of one group A streptococcal M-type renders insusceptibility to reinfection of that same type but not to the others. Treatment of choice is penicillin G, and erythromycin is used if the patient is allergic to penicillin. Nasal discharges are the most dangerous source for the spread of strep pyogenes. For the controlled procedures, detection and early antimicrobial therapy of respiratory and skin infections with group A strep is very important. We use benzathine penicillin G, 1 dose intramuscularly, and erythromycin if the patient is allergic to penicillin. Chemoprophylaxis in persons who have had rheumatic fever is also important. We still also use benzathine penicillin G, or daily oral penicillin or oral sulfonamide. Thank you for your kind attention.